Hello and welcome to our APLAR 2020 Congress Review. I'm Professor Takeuchi from Keio University, and with me is my colleague and co-host Professor Peter Nash. APLAR 2020 was the first virtual APLAR. As usual, it contained a mixture of key speakers, regional data reporting, updates from global experts. Before reviewing some of the key data, we wanted to highlight a couple of the very interesting key lectures from international colleagues. 2 decades of progress in rheumatology, what we have learned. This message is coming from Professor Ian McInnes, the CSF chairman, presented an excellent overview of the key development in the treatment of rheumatic diseases from the past 20 years and considered what the future holds. The Professor McInnes highlighted how remission was deemed impossible in the late 80s through the revolution of target therapies based on disease pathogenesis. Alongside the therapeutic advances, Professor McInnes highlighted the strategic changes that had happened with a greater emphasis on early intervention and treat to target. Looking to the future, earlier treatment targeting difficult to treat patients will be important, and newer technologies such as AI, genomics, and proteomics provide great opportunities. We strongly suggest you go to the APLAR website and listen to this great presentation. This is a message from the McInnes. So this is the message from the Professor Aretaha. He reviewed the need of a new remission criteria to achieve better outcome in NRA. He said, starting from the ACR Euro 2011 remission criteria, he examined how remission definitions have evolved over the last decades. Looking at Boolean remission, he considered the strong effect of pain in failure to achieve this, promoting how definitions are evolving to reflect these learnings. Again, please visit the APLAR website to get further insight to the development of remission criteria. This is a message from Professor Aretaha. Thank you very much. So, turning to the abstract from the meeting, a key area of research is always safety. The Professor Nash will highlight some key abstracts, including serious infection such as herpes zoster and tuberculosis, and their predictors and risks in patients suffering from RA. Over to Professor Nash.
Thank you so much, Professor Takeuchi. It's always very important to focus on safety. Even though we've had fantastic improvements in efficacy of our treatments, safety remains one of the very key areas. So this is a study presented by Russian colleagues from Moscow, where they looked at the predictors of serious infection in patients with rheumatoid arthritis who are receiving both biological DMARDs or targeted synthetic DMARDs. And they attempted to look at what were the predictors of serious infection amongst their patients. They looked at 1,052 treatment events in 772 patients from the Moscow Unified Arthritis Registry and found 44 serious infections. They looked at the independent patient-related predictors. We know that corticosteroid would be a predictor. We know that age has been shown to be a predictor. And in their studies, the dose of methotrexate and the doses of corticosteroids were positively correlated with the risk of serious infective adverse events. The relative risk was not particularly high, 1.12 per year, but there were associated risks. Smoking was a risk, the dose of steroids in a dose-dependent fashion, such that for every 1 milligram increase in corticosteroid use, there was a 16% increase in the risk of a serious adverse event. They also found the disease duration that they were in the registry and smoking were also independent predictors of serious infections. So it's up to us to try and minimize the amount of corticosteroid, to teach our patients to really stop smoking, which drives disease, drives risk, and blocks therapy. And the ones with the longest disease duration, the most disease activity, the eldest age over 65, they're the ones at extra risk. The next study we'll look at asks the question about tuberculosis risk in rheumatoid arthritis patients. And this was taken from a large centralized electronic database in Hong Kong. And they tried to determine the risk of TB in their RA patients. And as a control, they used patients with non-specific back pain. And they had something like 1,099 patients with rheumatoid arthritis. They had 2,500 patients with low back pain as a comparator group. And really the risk of TB, because I'm sure the Hong Kong doctors are very rigid about screening. They check history, they check examination, they do chest x-rays, quantiferon golds, etc. I'm sure they screen their patients. The actual risk was quite small at about 1.2 per 1,000 patient years and about 0.74 per 1,000 patient years in the low back pain patients. They also had the risk in the general population, which was 0.58 per 1,000 population. So they followed these patients and they adjusted them for all the comparators and the confounders. And they did find that if you had rheumatoid arthritis and needed DMARD therapy, low-dose corticosteroid, methotrexate therapy, that your risk of TB was 2.5 times higher than in patients with non-specific low back pain. And in their particular study, the independent risk factors were having had a history of TB or being on etanercept and other TNFs. Now, etanercept, I'm sure there was some selection bias because it seems to have a lower risk in many registries compared to the monoclonal TNF antibodies. So I'm sure the highest risk patients were selectively pushed towards etanercept if they were going to use a TNF in their at-risk patients. So bottom line is the risk of TB is 2.5 times higher if you've got rheumatoid arthritis, and the TNFs, as we know, were an increased risk factor, but really the risk was pretty low if you screened properly and you treated latent TB and you were on top of the risk. The next study looks at the NINJA registration database. They looked at the 75 patients who developed new TB and the age of onset of aging, the usage of biologics increased the risk, and there was a degree that extrapulmonary TB was high in that group who used the biologic agents. Herpes zoster is a major issue in the Asia-Pacific population. We know for genetic polymorphism reasons, the Asia-Pacific region has a higher risk. This was a study that looked at biologic agents and looked at JAK inhibitors, and it found that JAK inhibitors had a 6.85 per 100 patient year crude incidence of herpes zoster, whereas the TNFs, for example, and the IL-6 inhibitors and abatacept, about a 1.68 per 100 patient years risk. So a tripling of risk going to the JAK inhibitors. They looked at risk factors, and really the JAK inhibitors drove the risk. We have to be aware of zoster and think about vaccination, particularly when agents like anifrolumab are coming to our lupus patients who are always at the highest risk, even higher than rheumatoid. The next slide is the pulmonary involvement during rheumatoid arthritis. This is one of the commonest extra-articular manifestations. It's associated with morbidity and mortality. And they looked at the risk factors for developing pulmonary involvement. And it was smokers again, the presence of high seropositivity for APLAR, elderly, and the disease activity as well. Sjogren's syndrome and methotrexate, interestingly, were not risk factors, but we have to be aware of pulmonary disease and pulmonary involvement. And at the ACR meeting just coming by, there's a nice abstract on some genetic risk factors in the Japanese population. So I'll hand over to Professor Takeuchi.
Well, thank you very much, Professor Nash. So here are several questions to you. The first question is that what are the key safety factors to consider when using JAK inhibitors?
Well, when I'm about to start a JAK inhibitor, I always think about vaccination for zoster, whether the patient has had zoster or not. I think about both clinical risk factors like opportunist infection, make sure the lymphocyte count is above 500. And we've now doing that with flunamide, cyclosporin, azathioprine, all our drugs. 500 seems to be the level where opportunist infection is higher if you drop underneath that. We keep an eye on lipids, liver tests, white cells. These patients are often on methotrexate, so we're following these things anyway. And they're the kinds of things, CPK and creatinine, as we move forward. We try and minimize steroids, we try and minimize anti-inflammatories, and we've not seen an issue with gastric perforation.
Okay, thank you very much. And how was the risk of TB influence the decision to use the JAK inhibitors?
TB particularly doesn't worry about JAK inhibitors. The take-home message is these drugs are just as immunosuppressive as any other agent we use, and therefore we have to simply screen, we have to take a history examination, chest x-ray, quantiferon gold, treat latent TB, and vigilant while they're on treatment.
Yeah, thank you very much. And Herpes Zoster, you answered already, so thank you very much for your nice answers to such questions. Thank you very much.
Thanks.
So we would like to move to the second topics, the remission and difficult to treat RA. A key focus in patients recently have been difficult to treat patients. We now consider abstract looking at remission and difficult to treat RA, DTRA, and their characteristics. This is will also include interesting abstract on drug responses and molecular remission in patients with RA. So this is the abstract of the characteristics of difficult to treat RA. The background, as you know, that despite remarkable progress in therapy, some patients with RA have not achieved treatment target, such as remission. So the aim of this study is to clarify characteristics of the patient with difficult to treat RA in real world. They recruited more than 1,700 consecutive patients at Keio University were included with 237 identified as difficult to treat RA. A definition by a not targeted clinical remission or low disease activity after 1 year treatment with a T2T strategy. So characteristics of such DTRA patients were the mean age of 70, 90% female, and the disease duration is such as 14.8 years. Current treatment were CS-DMARD alone in 40%, BDMARD were JAK inhibitors in more than half, and glucocorticoid in around 30%. The cause of such DTRA were unresponsive to several biological agents or JAK inhibitors in 23%, comorbidities in 34%, and personal reason, such as cost and side effect of the drug is up to 40%. So patient characteristics were significantly different between the causes of DTRA, such as age of RA onset, the history of serious infections. So conclusion is here. The 40% of the patients with RA were difficult to treat in real world in spite of intensive treatment. This is a report from Japan. Another abstract from Japan showed that the high titer of rheumatoid factor and high baseline DAS28-ESR, HAC, and higher rate of lung and neurological diseases are associated with DTRA. They followed up 46.6 months And they found that 7.9% of the patients, 672 RA patients, were found to be DTRA. They finally investigated the multivariate regression analysis. They showed that high titer, high rheumatoid factor titer, high initial dust-to-immunity ESR, and complication of lung disease as factors associated with DTRA. So the conclusion here is the initial dust-to-immunity ESR and complication of lung, as well as high rheumatoid factor, are critical determinants of DTRA. And so this is the baseline factor predicting the DTRA. So this is the unique study investigated the molecular signatures, definition of the molecular remission for further understanding of drug response in RA. And the background of this study is the study aimed to develop a metric that unifies RA-associated variables for an objective assessment of drug effect, and took multiomics approach to define the molecular signatures for transcriptome, proteome, and immunophenotype. They found that the treatment with anti-TNF and anti-IL-6 receptor induced molecular remission more commonly than MTX, even though they equally induced the clinical remission. And molecular remission defined as a molecular profile closer to controls than RA patients. The follow-up suggested molecular remission was associated with long-term stable clinical remission. This study identified molecular signatures that were resistant to drug treatments. So the residual molecular signatures that is resistant to normalize the signature were associated with RA independently of known disease severity indexes and 4 pathways, including interferon signaling, identified. The conclusion here is high-dimensional phenotyping defined the molecular remission state in RA and revealed the molecular signatures that are still not reaching to healthy controls, even with clinical remission, such as high interferon signatures.
So thank you, Tom. That was a fantastic paper you presented on the molecular monitoring for remission. Do you think it's something we could use in clinical practice?
Unfortunately, at present time, we could not find the very potent biomarker that is useful in clinical practice. So we need to investigate it further to identify a useful molecular biomarker in clinical practice.
I love the dissociation between what we think is clinical remission and what you found to be molecular remissions. Very exciting study. Thank you so much.
Thank you.
What kind of characteristics in our difficult to treat patients will change the way we manage our rheumatoid patients, do you think, from these studies?
If we know the molecular, if we know the clinical characteristics of the patient with DTRA, we initially intervene early for that patient. So such information would be useful in clinical practice. What types of the patient with DTRA?
So I think we should tell our regulators to let us get access to better therapy earlier on if they're very high DAS-ESR, lung disease, high rheumatoid factor.
That's right.
The dream. That's the dream, yes.
Yes, thank you.
Very nice. Thank you very much, Tom.
Thank you. Thank you very much.
Okay.
So the next topics is by the Professor Peter Nash. For patient-reported outcome, please go to the PRO.
So thank you, Tom. PROs are very important. The patients are only interested in pain, fatigue, quality of life. They don't care about swollen joints. They don't care about erosions. So PROs are increasingly important. And there were a number of nice studies that looked at PROs. The first one we highlight here looked at comorbidities and how that is related to disease activity in patients with rheumatoid arthritis from a register-based study. And this was a nice study that looked at the relationship whether disease activity outcomes and comorbidities were correlated. And the bottom line was that the high disease activity group of rheumatoid arthritis had the highest risk for comorbidities, in particular cerebrovascular disease and respiratory disease, and quite a low rate of use of methotrexate, suggesting that the differences were driven by age, by sex, by undertreatment, including methotrexate and biologics, rather than overtreatment, which was reassuring for us. There's a window of opportunity and we to be more aggressive if we're going to deal with the usual comorbidities as evidenced in this study. The next one looked at depression. It's the kind of thing that we rheumatologists underestimate. We never ask our patients about how depressed they are related to their symptoms. And this very nice study showed that if we don't assess the mental state better, if we don't diagnose depression, then functional disability, quality of life, and our outcome measures will be affected, and we'll never get our patients to treat to target, because there's a very significant element that is driven by the mental health of our patients. It's a timely reminder that we should be thinking about mental health and depression and treating it just like we would treat any other symptom. A very nice study indeed. Thank you.
The one is, since there are high prevalence of depression in patients with RA, do you think we should apply or improve on our current patient support program, and how should we do?
Well, we've been using the Beck's depression inventory, but the patients are very sensitive. If you even mention, are you depressed? They think, do you think my pain is in my head, doctor? Is it not real? So the way you tackle the assessment and the treatment of depression is really very tricky in rheumatoid patients, but I think we under-assess it and we under-treat it, and it has a negative effect on our outcome measures and predisposes patients to changing, switching, escalating therapy, when really what they need is to be assessed and managed for their mental health.
Okay, thank you very much. So let's move to the individual drug of the interest in this APLAR 2020. So first a drug is the filgotinib. So the cytokine signaling forum is especially focused on the JAK inhibitors, and we will now consider the result for these. Firstly, we will consider filgotinib, starting off with a post-hoc analysis of FINCH-3, authored by Professor Tatsuya and his colleagues. Here you can see the efficacy of filgotinib in patients with rheumatoid arthritis with poor prognosis factor, PPF. This post-hoc analysis of FINCH-3 that is recruited MTX naive patients. So as you may appreciate in the key result from this post-hoc analysis of FINCH-3, the patient with poor prognosis factor, PPF, receiving treatment 1, and that is a filgotinib 200 plus MTX versus MTX, had higher frequencies of ACR 20, 50, 70 response and greater improvement in HAQ-DI at week 24. And responders were numerically greater for filgotinib 200 plus MTX treatment 1 versus filgotinib 100 plus MTX treatment 2 or MTX treatment 3. Treatment 3 is filgotinib 200 mono. And then the proportion of patients with poor prognosis factor receiving filgotinib 200 plus MTX treatment 1 who achieved DAS28 CRP 2.6 remission or CDI lower than 2.88 CDI remission and SDI remission and Boolean remission at week 24. That was larger compared to MTX monotherapy and numerically greater compared to filgotinib 100 plus MTX treatment 2. The conclusion here is the filgotinib treatment provided rapid disease control in patients with poor prognosis factors compared to MTX alone. There are another abstract you can see here, a subgroup analysis of the efficacy of filgotinib in demographic and clinical subgroups of patients with refractory rheumatoid arthritis. Impact of baseline demographics and clinical characteristics on filgotinib efficacy in patients with active RA who had inadequate response to more than one prior biological DMARD. This is the most tough patient to treat in RA. So in this study called FINCH2, the authors investigated the subgroup including 6 at birth, rheumatoid factor ACPA seropositivity, and disease duration and activity, CRP, use of corticosteroids, and different DMARD on ACR20 and DAS28 CRP. The key findings is that filgotinib improved clinical outcomes in such biological DMARD refractory patients, the most tough patient to treat. There was an absence of impact of disease duration, seropositivities, disease activity, and concurrent medication use, notably on the effectiveness on filgotinib. The conclusion is post-hoc analysis of FINCH2 showed us that the benefits were observed for filgotinib across subgroups defined by various demographics and clinical baseline characteristics.
So thank you, Tom, for a lovely summary of those 2 papers. They looked at difficult to treat patients, and the question really is, what is the place for the JAK inhibitors in those patients who are biologic DMARD inadequate responders?
Yes, such a data encouraged us to use JAK inhibitor after biological DMARD failure. Particularly, such data are very much encouraging because the patient background, regardless of the patient background, regardless of the previous biological DMARD, the filgotinib showed the similar efficacy across such a difference of the patient backgrounds.
So I think we learned you could get efficacy after an IL-6 inhibitor's failed going to a JAK, and also there's no point churning TNF after TNF after TNF. A different mechanism of action is better for the patients. Thank you very much, Tom.
Yeah, thank you very much.
So let's think a little bit about tofacitinib and its analgesic effect, because we have learned that the JAKs as a class work quickly and they seem to have an effect on pain in excess to their effect on swollen joint counts and acute phase reactants. This study also from, I think, Russian colleagues, they tried to analyze what they called subjective measures of efficacy, such as tender joint count HAC and the RAPID-3, and they compared that in a group of patients on biologic and targeted synthetic DMARDs with what they called the objective measures, like swollen joint counts and CRP. They looked at 832 patients. They analyzed tender versus swollen, HAC versus swollen, RAPID-3 versus swollen, and the same versus CRP. And they found that the JAK tofacitinib, the pan-JAK inhibitor, had significantly lower effect compared to other biologic DMARDs on pain and reducing pain compared to the TNFs and the other biologics. Now, these JAKs are not supposed to cross the blood-brain barrier, but they may be taken up peripherally in the peripheral nervous system, which is very rich in IL-6. So they seem to have a peripheral pain effect that exceeds the TNFs, is an advantage for them. They work quite quickly, and it means that maybe we should do some studies with the JAK inhibitors like tofacitinib in other chronic pain conditions, painful diabetic neuropathy, post-herpetic neuralgia, reflex sympathetic dystrophy. There's a whole series of chronic pain issues that maybe we should be looking at.
Yes,
So
thank you very much.
Thank you.
So how much of the direct effect on pain do you think we are seeing with the JAK inhibitor such as tofacitinib? Is this a direct effect on pain?
It's an interesting, and it seems to be across the class. If you look at select compare with upadacitinib, if you look at RA-Beam with baricitinib, and those two were head-to-head studies against the TNF with superiority, what drove the superiority was the effect on pain, patient global, physician global. There was no difference in swollen joint counts, ESR. So I think this pain is a class effect, it's real, it's a JAK effect, and we really should investigate it further.
Okay, thank you very much. So let's move to the another JAK inhibitor, the upadacitinib. So at this year's APLAR 2020, we have observed a large amount of data on upadacitinib, and therefore we will review some of the abstracts presented in APLAR, both in RA and beyond RA. Most of the data highlights the safety and efficacy profile of upadacitinib, with the first study from Dr. Kishimoto examining results from SELECT PSA-1. So, as you may appreciate here, the efficacy and safety of upadacitinib versus placebo and adalimumab in patients with PSA and inadequate response to non-biological DMARD, the called SELECT PSA-1. You may appreciate here the key result showed us that week 12 ACR20 rate were upadacitinib 50 mg, 71%, UPA30, 78%, whereas the placebo showed 36% and others showed 65% of ACR20. More patients achieved ACR50-70 with UPA15 and UPA30 versus placebo and UPA30 versus adalimumab. The improvements was observed with UPA15 and 30 versus placebo for all multidisciplinary controlled secondary endpoints, and UPA15 and 30 versus adalimumab for HAQ-DI, and UPA30 versus adalimumab for improvement in pain. The rate of AE and SAE, including serious infections, was similar with placebo, UPA15 and adalimumab, and higher with UPA30. Finally, the rate of herpes zoster was similar for placebo and UPA15 and 30, and no MACE were reported with UPA. The conclusion in this study is the UPA15 and 30 demonstrated improvement in musculoskeletal symptoms, psoriasis, skin disease, physical function, and pain and fatigue. And also the inhibited radiographic progression, and improvement was observed by week 2, the rapid onset of action in this PSA. This examined the efficacy of safety of upadacitinib in patients with PSA and inadequate response to biological DMARD, called SELECT PSA-2. The key findings were similar to PSA-1, that at week 12, no more patients on UPA15 and UPA30 achieved ACR20 versus placebo. The improvement was observed with UPA15-30 versus placebo for the many secondary endpoints. AE were reported at similar frequencies with placebo and UPA15, but a higher frequency with UPA30 in this AE. Numerically higher rate of serious AE were reported with UPA versus placebo. Herpes zoster was more frequent with UPA30. 3 malignancies occurred in each arm of the UPA. And finally, 1 adjudicated non-fatal myocardial infarction and 1 adjudicated pulmonary embolism were reported with UPA15. The conclusion, the UPA15 and UPA30 showed improvement across PSA, with improvement observed by week 2 in these tough patients, inadequate response to previous biological DMARD, and more UPA-treated patients achieved MDA and ACR 50 and 70. But there are some safety signal for UPA 15 and 30 here. This is the safety profile of UPA in Japanese patients with rheumatoid arthritis. The background here is this study assessed the long-term safety of upadacitinib in Japanese patients with RA from the upadacitinib developmental program. In Japanese patients, the treatment emergent rate of serious AE was higher in UPA-30 group compared to the 7.5 and 15 upadacitinib group. A similar result was seen for AE leading to discontinuation. EAIR of the herpes zoster was higher in Japanese patients compared with the total population, the global population. The conclusion here is that no new safety signals was identified in Japanese patients. However, herpes zoster is higher in Japanese patients receiving upadacitinib versus the global population. So next abstract showed us that the long-term safety and efficacy of upadacitinib again in Japanese patients with RA, that inadequate response to CSDMA, the study called Select Sunrise. The key findings, again, this is the upadacitinib improved or maintained efficacy from week 12 to up to week 84 in Japanese RA patients with CSD-MAD-IR. The patient who switched from placebo to UPA at week 12 showed the comparable efficacy improvement up to week 84 that is observed for originally randomized to upadacitinib at the baseline. No new safety signals was identified. The conclusion, upadacitinib is a favorable long-term option for Japanese RA patients with inadequate response to CSDMA. And this is the upadacitinib as monotherapy trial called Select Monotherapy Study, observed for up to 48 weeks, 1 year. The key result here is week 48, ACR 20 was achieved by 87% of the patients continuing UPA 15 and 30 milligram. And thus LDA was achieved by 72 and 80% for UPA 15 and 80, UPA 15 and 30, and 85 and 95% of the Japanese patients by UPA 15 and UPA 30. Overall, TAE 100 patient year were higher in the UPA 30 versus 15 arm for herpes zoster and hepatic disorders, and were comparable for serious infection and malignancy, excluding non-melanoma skin cancer. Adjudicated VTE were observed only on upadacitinib 15 milligram patients. The conclusion, UPA 15 and 30 resulted in similar improvement in RA signs symptom through 48 one-week observation. The overall benefit risk profile of both UPA doses were favorable. So this is the upadacitinib again in patients with RA and inadequate response or intolerant to biological DMARDs. Results up to week 60 from a Select Beyond. The key result here is the rates of TEAE were numerically higher in UPA 30 versus 15 arm of serious AE, serious infection, herpes zoster, and hepatic disorders. Among patients completing the week 60 on UPA 50, that is 80%, and 30 milligram, 83%. The patient switching from placebo demonstrated comparable efficacy on UPA throughout week 60s. The conclusion for long-term observation that the upadacitinib benefit risk profile in this refractory patients remains favorable without new safety signals. UPA 15 and 30 continue to be effective in treating signs and symptoms and improving physical function. So finally, the long-term safety and effectiveness of upadacitinib or adalimumab in patients with RA, up to 72 weeks observation from select compare study. The key result is AE of special interest 100 patient year for UPA versus ADA, were 3.7 for UPA versus 4.3 for ADA for serious infection, 0.9 for UPA versus 0.6 for ADA for opportunistic infections, 0.7 for UPA versus 1.0 for ADA for malignancy, 0.4 UPA versus 0.6 for ADA for adjudicated MACE, 0.3 for UPA versus 1.0 for ADA for VTE, and 0.6 for UPA versus 1.2 ADA for death. The event rates for 100 patient year base were numerically higher with UPA versus ADA for herpes zoster. That is 3.1 for UPA versus 1.2 for ADA. Hepatic disorder, 17.3 for UPA versus 14.0 for ADA. And finally, CPK elevation, 5.6 for UPA versus 2.1 for ADA. At week 72, ACR 2050-70 was achieved by 64, 51, 38 for UPA versus 53, 38, 24 for ADA. So finally, UPA demonstrated a safety profile consistent with observations through 48 weeks and durable clinical efficacy. Thank you for your attention.
The take-home message, the PSA data looks very nice. All the domains, imaging improved, but the skin response was very high compared to, for example, TOFA. They had half the patients having a PASI 100 almost, so that was very nice.
Yeah.
And the VTEs were balanced. The TNFIR study had 60-40-20, which is better than any other mechanism of action going to UPA. And the monotherapy study shows we can use that drug without methotrexate. Big advantage in many of our psoriatic arthritis patients, rheumatoid patients. Tom, do you think there's a difference in safety, APLAR region versus the rest of the world, other than that Zoster signal?
So far, there are no big difference between Asian and global data other than herpes zoster, such as the opportunistic infection or severe infection, so far.
You've now had experience, I think, with 5 JAKs. Do you see any safety differences with UPA compared to the other JAKs?
We don't know yet, because we need too much more data in real world. So we need to find which JAK inhibitors are different from others in real world.
And as far as efficacy is concerned, hard to separate them at this stage?
I can't see any difference among JAK inhibitors in the efficacy point of view so far.
And I think at least the VTEs were balanced in the UPA program. So we still have this question, is the VTE a JAK2 effect or a JAK class effect? And I think we need more time to work that one out.
Yes, and it is fortunate for us, the APLAR region, the patients, particularly the Southeast Asia or East Asia. We don't have the much higher instance of a VTE or ATE compared to the Caucasian patients. That is lucky for us. However, we should face infections such as the herpes zoster. So there is another issue in this area.
Fair enough. So let's move now to the APLAR region. And there were a number of abstracts that were looking at, for example, this one, the next slide presented on the Tuesday of APLAR, looked at the rheumatoid arthritis remission in the Asia-Pacific region. And these were all nice studies. They looked at logistic regression, comorbidities, non-use of steroids, biologics, and they came up with a remission rate which varied between the countries, with greater than 20% of patients achieving a deep remission, because it's no longer just getting to remission, it's how long you can keep the patient in remission that is most important. Next slide. Again, this was from a single center in Japan at the Keio University Hospital. And the question was, what were those factors that help achieve clinical remission, and what were the unmet needs in the very difficult to treat patients? And they could get 60% of their patients in remission, which is a very high number. And although the rest couldn't get to remission within a year, they looked at the factors that were associated with not achieving remission, and that was joint destruction, persistent pain, even when there was no inflammation, so from damage, multiple drug failure, other comorbidities, and not adhering to our therapy, the kinds of things that you would expect to lead to bad outcomes. The next slide looked at DAS remission and DAS low disease activity from rheumatoid patients from the United Emirates. And again, they felt that the majority of their patients were able to achieve remission or low disease activity. And those patients who had a long lag time to diagnosis and treatment, obesity and hypertension, were the ones that had the most difficult chance of getting to a remission or a high disease activity, whereas those on biologics and MTX users were much more likely to be in low disease activity. Next slide looked at Indian management. There was an RA registry. They're working on prescribing patterns, comorbidities, and a guide to establish policies which were most apt to this difficult region with access issues, vast numbers of patients, the cost of therapy, etc. So we look forward to learning in the future how to manage rheumatoid in the Indian subcontinent, and we wish them luck with their RA registry. Finally, there was a tertiary care clinic in Sri Lanka that looked at patients' attitudes towards medication, because we think patients take what we prescribe. You'll never get remission if there's poor adherence and poor persistence with therapy. So education, to have a positive attitude about their therapy, understanding their therapy, and in particular, clarifying the misconceptions. For example, many patients think these drugs will damage their organs long term. Many patients think they'll get addicted to these therapies. And all these misconceptions can be clarified, improving compliance and disease outcomes.
These series of abstracts cover a number of questions in the region, APLAR. So overall, what do we learn about the treatment of RA across the APLAR region?
I think we have to appreciate that there are many difficulties faced by many countries with access, with cost, with comorbidities, with patient education about their therapy. And these are all major challenges. But we must remember this region is 3 to 4 billion people, and we really have to work very hard to improve the outcome for these patients.
Thank you very much. Thank you, Peter. So I would like to thank you very much for Peter Nash and attendance today. This is for our Congress review. APLAR 2020 Virtual Congress certainly brought diverse topics and research as we discussed today. Even during a pandemic, it didn't stop us from learning. Thanks to modern technology, we can outreach our knowledge virtually. So finally, remember you can visit our website, www.cytokinesignaling.com, For more content, I hope you enjoyed our review of APLAR 2020. Thank you very much for your attendance. Thank you very much, Peter.